work or sickness certification practices among physicians, for instance, and hardly anything on consequences of being sickness absent, which is the type of knowledge that is needed in healthcare and among patients. What are the pros and cons of becoming sickness absent? Are there any risk factors with being that? How do we identify them and handle them? These are the main sick leave diagnoses. 70% of sickness absence are due to these diagnoses, and we have also less knowledge about them. We have much more knowledge about the diagnoses we die from, like cancer and cardiovascular disease. So this means that although sickness absence is a very common recommendation in healthcare, a lot of sick notes are written, and this should, as other healthcare measures, be based on scientific knowledge and be subject to quality assurance. This very seldom happens. So we need more scientific knowledge on psychosocial consequences of morbidity. I want to end with this, which WHO said already in 1986 and is repeating, that the fundamental conditions for health, irrespective of if you define it as a state or a resource, are peace, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and equity. That is still the situation, and that is one of the reasons why UFA also has to work with all the 4 pillars, including policy. So far, still, war, poverty, and infections are the main reasons for premature death in society. Thank you.
We now move to the second aspect of this plenary. And I think when you read in the book or in the program the title of this presentation by Professor Roger Ingham, I was intrigued, may I speak for myself. Discussing with Roger the subject, I got even more intrigued. Of course, Roger has helped us in Malta to develop our sexual health policy, being himself a professor of health and community psychology at Southampton University. He has been a consultant for WHO on reproductive health and AIDS programs. He is involved with the UK National Sexual Health and HIV Strategy and was research advisor to the Independent Advisory Group on the government's teenage pregnancy strategy. So without further words from me, I invite Professor Roger Ingham to discuss this very intriguing question. Can and should and how can private sex be a public health issue? Roger.
Good, thank you very much, John, and thank you to the organisers for inviting me over here. I've been doing research on sexual health for about 25 years, so what I can present now is just one small aspect of it. Let me try and say what we mean by sexual health. The emphasis tends to be on physical outcomes, HIV/AIDS, obviously, which really enabled research in sexual health to start. There was very little before that. Other STIs, early pregnancy, abortion. Psychological outcomes are also important, but are much less well studied, and this is where the mind and the spirit may enter things. But of course, a much broader definition of sexual health also includes all the issues about gender, about internet grooming, which is becoming an increasing problem in many countries, homophobic attitudes and stigma, sexual abuse, intimate partner violence, honour killings, female genital cutting, pornography, and so on. So sexual health covers really a very, very wide range of concerns. And ideally, the area will be fully integrated between mind, body, and spirit. What I'm going to do today is show areas of disjunction and try and think about why some of these disjunctions may occur. So, very brief overview. Many countries adopt a technical approach to sexual health. When I say many countries, I probably mean many European countries. Service provision and school-based education. But these are very vulnerable to funding cuts. They're rather pragmatically driven. So in England, we made a lot of progress once the Labour government set targets, but now those targets have been removed. It's not quite clear the funding will stay. and they're very influenced by the personal opinions of policymakers. There tends to be an emphasis on negative outcomes and guilt and shame. So sex in most countries of the world is governed by guilt and shame, which arises through various different ways, or public health is governed by reducing negative outcomes, such as reducing teenage pregnancy rates or reducing STIs. And there's a relative ignoring, looking across the world, of the issue of rights and entitlements to good sexual health education and good sexual health, and a relative ignoring of the role of positive experiences in sex, which we might say are more spiritual. Now, there are some exceptions, many of whom are in this room. So Sweden and the Netherlands, for example, or other Scandinavian countries have adopted a much more rights-based and positive approach to sexual health. And of course, they happen to have much lower teenage pregnancy rates as well. So there seems to be a link there which we need to draw out. And we have done quite a lot of comparative national work which suggests that that approach actually is very successful. So the public-private dilemma is that sexual activity is generally private, public health is generally public. How do these relate? How could they relate more effectively? And I want to make a distinction at the beginning between big P and little b. Big P is what people with suits and ties decide in Brussels and Geneva and Washington, people who make big policies that affect big things. Little p is what the rest of us do in our everyday lives. So every time we're faced with a decision, we have to make a policy as to how to respond to that decision. I'll give you some examples of that later on. Now, let me just stress, when I say sexual activity is private, when I was here 2 years ago helping to launch the Maltese sexual health strategy, the Minister of Health told me and others that he was very surprised one day walking with his wife in a place about 200 metres from here called Parcheville at midnight on a Saturday night and saw young people having sex on the bonnet of their cars. So you can say that's not as private as maybe it should be. This was quite shocking for him. So if any of you are staying tonight, Parcheville is about 200 metres down the road, so you can go and see for yourself what the Maltese youngsters get up to. So the plan is to summarise some data from 2 recent qualitative studies. I know public health people like numbers, but I thought I'd give you a bit of qualitative work. The first on young women's early sexual encounters, their attitudes to masturbation and pleasure, family communication, etc. And the second, a study that we're in the middle of at the moment, looking at parents' reports about how they answer young children's questioning about bodies and babies. And I'm going to try and make some links between those. And speculate on how some of the discourses that we have identified may arise and their likely impact. So first of all, a quote from a 17-year-old who's describing her first sexual experience when she was 15. It wasn't good the first time, it was bad. Actually, it didn't feel good. I mean, it was like me not being in control. I know you're supposed to feel out of control, but I was out of control for all the wrong reasons. Sorry, I know that don't sound right, but that's how I feel. I think this quote is remarkable for a number of reasons. One is the incredible self-reflection that this young woman is displaying about the notion of control, being in control for good reasons and being out of control for wrong reasons. And the second is the way she apologizes. We find this in a lot of our research, that if young people feel they're doing something which is not fitting an acceptable discourse within society, they apologize to our interviewers, which I find really quite interesting. There's much variation in individual experience. These quotes are based on a study we did of about 20 young people, all in the same area of England, all in the same college. So on the one hand, we just thought about it, like I didn't want to rush into it, and he didn't either. I never felt I was being pushed, and when it happened, we both really enjoyed it. I mean, it was a bit quick, but it was still nice. So this is an example of a premature ejaculation, as the clinicians would say, but spiritually and mentally, it was a very, very positive experience for her and presumably for him. On the other hand, I mean, I hardly have an orgasm with these blokes. I mean, it's all over too quick, ain't it? That's the way young women speak in England now. They sort of ask if you're okay, and I sort of moan a bit, and they think that's me saying, yeah, it's great, and I'm nearly coming. And so they sort of go for it, and before I know it, it's all over. It's not funny. I mean, I'm left there feeling all horny. If you're not quite familiar with these slang terms, ask me at coffee. And he's thinking, thank you very much, that was great, that's crap, ain't it? So these are 2 young women in the same college, similar age, describing their early sexual experiences. How is it that a similar behaviour, which, as I say, clinically and physically would be described as the same, can be psychologically and spiritually so completely different? And then in these interviews, we also asked about masturbation, and there's been very little work on female masturbation. Perhaps not surprising, I should say, I obviously have female interviewers. I couldn't do that myself. And again, we got tremendous variation. I would never touch myself, I think that's really disgusting. It's not right, because only a boy's supposed to touch you there, and even then it's not that great. I mean, only slags do that, don't they? Or middle-aged women who can't get a boyfriend. Now, luckily I can't see if you're nodding in agreement with these comments or not, but it's best to sit absolutely still. And then on the other hand, well, I mean, it's only after I've done it and I feel all chilled that I think, oh, that's why I was feeling all sort of tense and stressed, and it really helps to feel, well, not just well, but calmer. Well, that's how it is for me anyway. So across the range, we had quite a lot of variation, as I say, amongst this fairly homogeneous group. There were some possible links in the study as a whole between early and open family communication. So if parents answered their children's questions, or at least the young people reported to us that their parents answered the questions, we don't have an objective measure, because that would have meant a long-term longitudinal study. Comfort with bodies, positive views of sex, and gender equity, where the women were much more able to say what they did and didn't want, and greater control in sexual situations. And that meant either not having sex when they didn't want to have sex, or having sex when they did want to have sex, or if they did, insisting on contraceptive use or condom use, if that was appropriate. And there were many, many examples I could give of that. And when you look at this, this is within families in the UK, but actually very, very similar results come out of our cross-national work. So this would be a typical pattern in Scandinavia or Netherlands countries, that this somehow culturally, these are ingrained into the society. So what can we learn as public health people about what we can do to improve sexual health? Just 3 more quotes from some of our young people. Again, we do all this research. We spend millions of pounds doing research. And sometimes young people themselves tell us what we need to know. I'm not sure how to put this, but being, or at least knowing me, or at least my body, has really helped me, helped me know what I want. This is so personal, I find it difficult to talk about. I think I have more control. I can just put a stop to things I'm not happy with, when it's not right. Well, I tell them it's not always easy because they're all horny, but sorry, I just say if it's a quick shag you're after, forget it, because I'm here too. Know what I mean? So these, expressed in different ways, but these are assertive people who are prepared to say the right thing, look after their sexual health. The second project I want to mention briefly, we're halfway through it, because we got interested in that study about how it is young people ended up with such negative views about their own bodies or reasonably positive views. So we said, well, there's quite a lot of work on parents talking to teenage children about sex when they reach puberty and menstruation and so on. There's very little research on how parents talk to very young children, and all very young children ask questions like, where do babies come from? How did I get here? Why do I have one of these and my sister doesn't? Or why haven't I got one of those that my brother's got? And so on. So we're talking to a whole range of parents about how they address these questions, how they answer them, and why they answer them the way they do. So we're halfway through it. We've got quite a lot of data already. There's a very clear desire amongst the vast majority of parents to be open and to be better than their own parents were. There are some cultural differences here. Some of our ethnic minority groups say children really don't need to know anything about that, not just until they're older, but ever. But a lot of the parents who did want to be open identified some very clear barriers. So this notion of perceived threats to childhood innocence, this comes up frequently. We don't want to destroy our child's innocence. Now, the opposite of innocence is guilt. So this discourse is setting up a contradiction between not knowing about sex and feeling guilty about sex, and that's quite an interesting contradiction. It was very similar in the early days of HIV, when you had innocent victims of HIV. These were people that had blood transfusions, as opposed to guilty people who had sex with other people, often of the same sex. A concern with age appropriateness, they will say, we'll tell them the truth when they need to know. And we say, how do you know when they need to know? Because they'll ask us. So in other words, the child is driving the agenda of what they talk about, but how does the child know what the agenda is until they know what questions to ask? So again, this is a very passive approach to educating young people about things that actually they need to know. And then a fear of other parents and schools' reactions. We've had many people say, well, I want to say more, I want to use different terminology, but I know that if I do, and my child goes to school and uses those words, other people's parents will complain, or the teachers will complain, or I will get reported to the authorities for being too forward with my children. So there are huge barriers to parents doing what they know they want to do and intuitively feel that they should do. So some of the implications of this study, we're looking at reactions to early bodily questions and explorations, reactions to early reproductive questions, much of the early discussions about reproduction. And it's an interesting conversation. Mummy, where did I come from? Some people say you're a gift from God, which may well be true, but others say it was a special cuddle. A special cuddle, what does that mean? It's not very informative, but it also links sex with reproduction only. And some parents find themselves trapped in a conversation if there's an only child. So if you and Daddy only had sex once then. And that's a very embarrassing situation to escape from, unless you're saying, well, we tried many, many times, but you were the only one that came along. So in other words, we're separating the whole process of sex and love from its normal function. Naming of body parts, a lot of embarrassment about what we should call body parts. We come up with all sorts of strange names. One of the common ones in England is front bottom. Now, actually, when you think about the bottom, it is actually quite dirty and unhygienic, and you do have to wash your hands when you've touched it. So by calling a woman's genitals a front bottom is saying something about dirtiness and disgust about that part of the body. And it may be that links up to some of these negative views that we've heard. And if you talk to clinicians, they do often get women who have problems inserting tampons, for example, because they have such a negative view about their own bodies. It may be linked to this. We don't know. We haven't done a random control trial. I'm not sure how we could. So what is the impact of silences and evasion when parents say you're not old enough yet, or ask your father, ask your mother, ask your teacher, whatever, ask anybody but me? It leads to a general mystification of bodies and sex. It leads to an inability to communicate and discuss. It increases the likelihood of guilt and shame. We've asked parents how they respond when children start playing with themselves in the bath, for example, as most children do. Do they regard it as something that should be stopped, that's naughty? Don't do that, it's wrong, it'll fall off. We've heard parents say that. And so this gives young people a very strange sense of their own bodies. And then what is expected of boys and girls? And I won't go into this, but I'm sure you can imagine that girls are taught much more in terms of protecting themselves, in need of protection, rather than being active agents in sexual encounters. So I want to give some examples of some of the social and cultural processes that may occur to help parents feel uneasy to talk about some of these issues. These are not high-level pronouncements. Of course, I could give lots of quotes of those from different church authorities or different politicians. But these are two everyday situations. The first is called Nisha and Joe. It's a booklet. I have it here. If anybody wants to see it, have a coffee, feel free to ask.